Yes, Your Honor.
All right. Dr. Lawson, I'll ask you to come to the podium and pause momentarily, and I'll swear you in, please. If you'll raise your right hand. Do you solemnly swear or affirm that the testimony you're about to give will be the truth, the whole truth, and nothing but the truth, so help you God?
Yes, Your Honor.
All right, I'll ask you to have a seat right there in the witness box. And Dr. Lawson, for purposes of presenting your testimony via the video deposition to the jury, I'll ask you to speak clearly and into the microphone. The videographer is a certified court reporter, and he will be preserving the deposition for purposes of submission to the jury during the trial.
Yes, Your Honor.
Would you state your first and last name for us, please?
Yes, my first name is Christy. My last name is Lawson.
Can you spell that, please?
CHRISTYLAWSON.
Thank you. General Ray is conducting the direct examination. May I ask?
Dr. Lawson, what is your occupation?
I'm a trauma, critical care, and acute care surgeon at Johnson City Medical Center.
And are you licensed in the state of Tennessee?
Yes, ma'am.
How long have you had a license in the state of Tennessee?
Since 2010.
Have you had any license in any other states prior to that?
I was briefly licensed in the state of North Carolina.
And when did you have that license?
It would have been in 2017.
And then was that dual license?
It was dual license, yes, ma'am.
And what medical school did you attend?
I went to the Medical College of Georgia in Augusta, Georgia.
And where did you intern?
I did my internship at the University of Tennessee in Knoxville.
And what did that internship consist of?
Internship for surgery residency is a year of rotations on general surgery services and rotations. It's a full year, calendar year, just broken up into different subspecialties. The remainder of my training was residency for 4 subsequent years.
And where was your residency?
My residency was also at the University of Tennessee Medical Center in Knoxville, Tennessee.
Okay. Since that time, where did you practice?
My first 6 years of practice remained at the University of Tennessee in Knoxville, and then I subsequently transferred my care here to Johnson City Medical Center. My start date was April 1st of 2018.
And has your nature of practice been the same the whole time that you've been with the Johnson City Medical Center?
Yes, ma'am. I was employed by Johnson City Medical Center to provide trauma, critical care, and emergency general surgery services.
Have you had the opportunity to do teaching?
Yes, I'm a professor of surgery at East Tennessee State University. I teach medical students and residents in the art and discipline of surgery.
And how long have you been doing that?
Since my career began in 2010, I've been an academic professor, or I've gone through the academic hierarchy teaching since I started practice in 2011.
Have you ever been published?
Many times.
And can you give us an example of some of the publications?
My most recent publication was a couple of months ago on ileus as a marker of critical illness and sepsis in trauma and critical care patients.
And what was the one before that, if you recall?
I did a case study on Bacteroides chauvini, which is a rare bacteria found in humans in farming accidents, and we had a presentation at Southeastern Surgical Congress in February of 2023 on that paper.
Here at this time, we attend her as an expert in acute trauma and emergency general surgery services.
Any objection to that designation from defense? All right, without objection, Dr. Lawson will testify and is declared an expert in the field of treating patients with acute trauma and in general surgery as well. The jury will be instructed that her testimony is to be viewed as an expert in those particular fields.
Around August the 10th and 11th, did you have the occasion to see Sheila Marie professionally?
Yes, I was the attending surgeon on call when she brought in by emergency medical services to the trauma center at Johnson City Medical Center.
May I ask August 10 and 11?
Yes.
What year?
2019, sorry.
Sorry about that.
In my head, I said that. Can you describe her condition at the time that you saw her?
If you will give me a moment, I'm going to pull up my history and physical from that time in this packet. I was on call the evening of August the 10th of 2019. It was dated that we were notified the patient was arriving at 17:12. I'm reviewing the medical history in front of me because this was quite a few years ago, and I didn't remember until I reviewed the medical record. Once I reviewed the medical record, I have a very clear memory of Miss Murray. She arrived to the trauma bay by EMS transport, covered in feces and vomit. She had contractures and was unable to move her arms. She had a open fracture dislocation of her lower extremity.
I want to ask you to explain to the jury what contractures are.
Of course. Contractures are where you have been lying immobile for a prolonged period of time with atrophy, which is wasting of skeletal muscle, and immobility, which makes the muscles draw up and the joints draw into the body, and it compresses against the chest wall or against other parts of the body, causing pressure. It's seen in stroke patients or in patients with prolonged immobility and malnutrition, in patients with cerebral palsy, anything that causes muscle spasticity and contracting that is not able to be moved by either passive or active range of motion, and we could not extend joints.
Okay. I'm sorry, if you'll continue with...
Yes, ma'am. She had an open fracture dislocation of her lower extremity with exposed bone. There was a significant amount of infection present there. She also had multiple wounds over a large portion of her body from these contractures related to pressure necrosis. There were wounds on her backside, there were wounds on her elbows and her feet, and there were wounds that I recall, a significant wound on her breast where it had been pulled up underneath her axilla on the right side, which is her armpit, where her arm had contracted down on top of it. And those pressure areas had caused the skin to die and the underlying soft tissue to die.
So, if I understand that correctly, what you're saying is her right breast was under her arm.
That's correct.
And left in such a long time that the tissue had died.
That's correct.
And was there anything else that...
On our documentation, she was noted to have some aging processes in her eyes with cataracts present. She was noted to have severe muscle wasting, loss of subcutaneous fat, and signs and symptoms consistent with severe malnutrition and dehydration. She had wounds on her perineum, which is around where her vagina and labia are, also from pressure and laying in the same position for protracted amounts of time. And again, this fracture of her lower extremity was significant, and her foot was at a right angle to her ankle instead of in normal anatomical alignment.
And were photos taken of the injuries that you have noted?
Photos were taken after admission to the intensive care unit. I do not believe the photos were taken immediately in the trauma bay, as that's not usually our practice to do so.
And what would have been different about her appearance in the trauma bay versus ICU?
When she was admitted, she was clean, and all of her wounds were clean so that we could better appreciate the full surface area of the wounding. She was covered in feces, and we had to extensively clean that off of her body prior to taking these photos. Our nursing staff in the ICU spent a good long amount of time cleaning her before these photos were taken.
I'm going to ask the bailiff to hand you a set of photos. We're going to go through those individually, but I'm going to go ahead and hand you the whole packet.
Yes, ma'am.
The first photo in front of you, what is that picture of?
This photo is a photo of her foot and ankle. It's difficult to fully appreciate in this photo because you can't see the remainder of her body, but her leg and her foot are not in normal anatomical alignment. And this area of black and open wound is her tibia, the end of her shin bone that comes out and usually is in normal alignment with your ankle to provide a place to walk.
Okay. And obviously I know it's not normal for that bone to be sticking out, but is it normal for it to be black?
No.
Why is that significant?
When a fracture is fresh and acute, you can see clean marrow edges. They're red, they're weeping, there's normal fluid that comes out of the body after an acute injury. It's part of the inflammatory process. Our body responds to acute injury by bringing in fluid to that area. It's sort of like if you think about pulling a muscle, there's swelling. This was an old injury, and you can tell that because there was no immediate swelling, there was no fluid, there was no weeping, there was no active bleeding, and the blackness at the end of the bone is indicative that the bone had been exposed to a dry environment for a protracted amount of time to the point that it was beginning to die.
Let me ask you, was Ms. Murray able to give you a verbal history?
No, ma'am. Miss Murray was documented in my history and physical as having a Glasgow coma score of 9. And what that means is that she had spontaneous eye opening, so she was doing that on her own. She made incomprehensible sounds. All we could elicit from her when questioning her was a moan. She was not speaking or articulating with words. And it indicates that she had posturing, a flexure posturing, and that's where when you give a stimulus, usually we will rub the sternum, sometimes we'll pinch the nipple or the earlobe to give a noxious or painful stimulus to the patient to see what their response is. A normal response would be to push your hand away to make that stop, and hers was a flexion posturing where she pulled in like this, but didn't push us away.
And as part of your treatment, is it a normal practice for you to go back and look at her prior history?
Yes.
And did you do that in this case?
It's a normal part of our practice to do so. We had looked back in the medical record and wrote that she had some past medical history consistent for a stroke, high blood pressure, a history of DVT, which stands for deep venous thrombosis, which is a clot in the lower extremity, that she has a clotting disorder called factor V Leiden, which is just an inherited clotting disorder that allows patients to be much more prone to blood clots. And I'm having trouble reading the photocopy, but it also said that she's been bedbound for years and had previously been in a nursing home. All that would have been obtained not only from the history that we found in the computer, which is an old electronic health record that we no longer use at Johnson City Medical Center, is not easy to access, so it's all printed documentation that you provided, and also from the emergency medical services who would have brought her in.
Okay. And so in this case, are you aware who provided additional information with regard to her health?
The emergency medical services personnel who brought her in provided the scene information and the transport information. They would have told us some of this history. It is pretty matter of routine that they would have asked family present at the time that they picked the patient up for any history that was pertinent.
Was there any information received that you reviewed with regard to the cause of the injury to her?
No, there was no one available for us to speak to with regards to the family, and we did not have any information about what happened to the patient to create the injury. EMS provided us the information that she reportedly fell several days prior to that at home, and that the family had called when they noted the wound, and that was all the information we were providing.
Your Honor, at this time we would ask that the photo of the ankle be admitted as State's Exhibit 1.
All right, no objection. The photograph identified by Dr. Lawson depicting the ankle as she encountered it from Ms. Murray upon her admission to the hospital will be marked as Exhibit 1 to her deposition.
Can I ask you to look at that second photo?
Yes.
And what is it?
And if I may note, excuse me, that will be marked and moved into evidence for purposes of later submission to the jury.
This photo is, this is a post-operative photo after Ms. Murray would have gone to the operating room with our orthopedics team. This photo has, you can see in the top portion of the photo, an external fixation device. That is a device that we utilize to realign bone and put pins and stabilization devices into bones that are deemed to be too contaminated to put internal hardware. And so she has that. The tubing that's present in the picture would have been part of either the sequential compression device, which is designed to help prevent blood clots, or what's called a Prevena, which is a vacuum-assisted wound management device that brings fluid and blood out of the wound to try to promote healing in a clean environment. We use that for contaminated wounds after orthopedic surgery. The remainder of the pictures, there's bruising on the top of the foot. There's these are chronic nail changes. This on the toe would have been one of the pressure wounds, and there's petechiae, which are just small pinpoint bleeds that could have been encountered during surgery with the attempt to reduce the fracture.
Your Honor, at this time we ask that be marked as State's Exhibit 2 and moved into evidence.
All right, this photograph is after the surgery was performed on her ankle.
Yes, Your Honor.
All right, that will be Exhibit 2 without objection, marked and moved into evidence.
And in case I didn't get that in there, which ankle was that?
I'm going to look back to make sure that I don't say incorrectly. It's the right ankle.
I'm going to ask you to look at the third photo.
Yes, ma'am.
And what is that photo of?
This is a photo of a pressure wound, I believe, of the elbow. If I can, it's hard to tell if it's the elbow or the heel, just based off of the zoom in.
I think if you flip it,
And it's the heel. Sorry. It's of a joint space, and so it's very common to see pressure ulcerations on joints because they're areas of natural pressure where we will put naturally our elbow down or our heel down, and this being the heel, this would have been where the heel would have rested on a bed for a protracted amount of time.
And is there things that can be done to help with pressure wounds such as this type?
Pressure wounds are a very difficult problem in bedbound patients. They're known to happen when patients are immobile. Prevention strategies include offloading pressure, so keeping certain parts of the body elevated. For heel protection, we can put pads that are soft called Duoderm or Methylex on them, and they are available usually through home health agencies or durable medical equipment agencies to protect those surfaces that naturally rub. And then the mainstay of prevention of pressure ulcers is mobility, rotating and turning patients, which gets really difficult with prolonged immobility, and also proper nutrition. Without proper nutrition, pressure ulcerations happen and they do not heal.
And if I move that one into evidence, you still have the photo?
Yes.
Your Honor, I'd ask that be moved into as evidence in State's Exhibit 3.
All right. And without objection, let's see. That would be the left heel. The left heel, as described by Dr. Lawson in the photograph, will be marked as the Exhibit 3 moved into evidence.
I should look at photo number 4.
It's photo number 4.
Yes. And what is that picture of?
This is a picture I would presume to be her left foot, given that it looks very markedly different than the right foot. There is a pressure necrosis at the metatarsal head, which is the head of the toe joint of the fourth and fifth toe, and there's chronic nail changes, and you can't tell, but there's also a pressure wound underneath the digit of this toe, where you can see the skin edge peeling back. So there were multiple pressure wounds on this foot.
Your Honor, we'd ask that be moved as State's Exhibit 4.
And that was also the left foot.
Yes, Your Honor.
All right, that will be Exhibit 4 marked and moved into evidence.
And the next photo?
This is a photo of, I believe, her left leg, if I'm not mistaken. This is just indicative of chronic skin changes related to aging. There is subcutaneous fat loss consistent with her diagnosis of malnutrition, and the dark is hemosiderin deposits. That's from peripheral venous stasis. This might have been the site of her DVT or her blood clot. I'm actually unsure, and it's not documented in my history which leg the DVT was in, but it is really common to see deposits of blood in the skin after a blood clot and prolonged immobility.
And in that photo, there's a line that goes down the middle of her leg. Is that of any significance?
Honestly, it could just be a fold in the skin from edema, from the sheets. It's difficult for me to tell if that was a true pressure wound or if it was just creasing in the skin, and I do not recall.
Here we ask that be moved as evidence as State's Exhibit 5. That would be the left leg.
Without objection from the counsel, the photograph described by Dr. Lawson of the leg and skin covering the leg of Sheila Murray will be marked moved into evidence as Exhibit 5.
Get a moment. Okay. And what is that photo?
This is a photo of Miss Murray. You can see her face in this photo, which is like a little more emotional. This photo shows the signs of severe malnutrition. She has, you can see rib margins of almost every rib in her chest wall. You can see the evidence that at one point she was a much larger woman. She's had a lot of stretching of her skin, and a lot of her subcutaneous fat is gone, and that has left just skin folds and redundant tissue from, at one point or another, large volume of subcutaneous fat deposits that are now gone. She has evidence of severe cachexia. Cachexia is when you lose skeletal muscle mass from wasting and malnutrition. You can also see in this tube she has a nasopharyngeal tube that we place. That's the yellow tube going in her nose. It goes in her nose into her intestine to provide medications and nutrition. We would have placed that upon admission to the intensive care unit. This is her abdomen, and it's scaphoid, which means that it's indentated in, and that is just, again, a sign of malnutrition. And then the square is blood out of her left breast and the wound on that breast.
At this time, we'd ask that be moved into evidence to state exhibit number 6.
Without objection, the photograph just described by Dr. Lawson depicting the face and upper body of Miss Sheila Murray as she saw them in the hospital. The Johnson City Medical Center will be marked as exhibit 6 and moved into evidence. Is that correct?
And the next photo.
This is a photo of Miss Murray's left elbow, again depicting pressure necrosis of a joint, which is a common place to see pressure necrosis. And then here on her skin fold over her left would have been her rib cage, and the beginnings of her ptotic breast are some petechia, and that would have been where her arm was pressed up against that side of her chest wall from her contractures or her skeletal muscle tension.
Here we ask that photo of the left elbow injury be moved into evidence as states exhibit number 7.
All right, without objection, the elbow that's depicted with a blue glove and the medical personnel is marked as exhibit 7 and moved into evidence.
And the next photo.
This is a photo of Miss Murray's ear. The medical device is a oxygen saturation probe that we would have placed on her ear so that we could obtain an accurate saturation of how much oxygen was in her bloodstream. It looks as though this is blood from the external auditory meatus, which is the ear canal. There was some dried blood present at the time of admission, noted on my history and physical, and this would have been drainage from her ear, and there was a little bit of a pressure necrosis of the earlobe as well.
Here we would ask that photo of the left ear be moved as states exhibit number 8.
Left ear. The left ear.
Yes, Your Honor.
All right, without objection, the photograph just described by Dr. Lawson of the left ear of Miss Sheila Murray will be marked and moved into evidence as exhibit 8.
I'm going to ask you to look at the next 2 photos together.
Yes.
And what are those photos of?
These are photos of Miss Murray's right breast. This was the breast that was up underneath her right axilla, and it was pinioned underneath her armpit from the contracture of her right arm. The medical personnel who documented the history and physical on admission, it would have been one of my resident physicians. She documented that she felt the patient had had a mastectomy, and upon further evaluation of the patient, once we were able to place her in the ICU and do a better exam, we found that she had not had a mastectomy, but that her breast had been up underneath her axilla for a prolonged period of time, and this is a picture of pressure necrosis of the nipple areola complex of the right breast.
Would this be something that would have happened over a day or 2, or?
No, this would have happened over a period of weeks to months, most likely. This degree of necrosis, you can see there's already tissue death of the nipple itself, and there's fibrinous exudate, which is fibrin is a byproduct of wound healing. This wound had been going on for so long that it was attempting to heal itself and was unable to do so because of continued pressure. This is very commonly seen in advanced deep tissue injuries. We call them stage 4. Which means that they have gone from a redness of the skin through the top several layers of skin and have involved not only the dermis and the deep dermis, but also the fat under the skin. And it's indicative of chronic and prolonged pressure changes.
And would that be something that would be treatable before it got to stage 4?
Removal of pressure is how you treat the beginnings of a pressure necrosis. Our practice is when we notice the beginnings of deep tissue injury, the first stage, stage 1, is indicated by redness of the skin. Once you start seeing those skin changes, if you do not offload pressure appropriately, then they will progress. So yes, they can be treated prior to the development of open necrotic wounds.
And if the pressure is removed, does that stop the pressure wound?
It tends to stop it from progressing. Does not necessarily mean that it will heal. Malnutrition contributes to lack of wound healing.
Here, we would ask that the next 2 photos be collectively exhibit 9. If the full right breast photo would be 9A, and then the cropped of just the lower part of the breast, the nipple area with the infection would be 9B.
All right, Exhibit 9A is the entire, you said it was the right breast?
Oh, yes, ma'am.
That will be Exhibit 9A. Thank you, ma'am. And Exhibit 9B will be the closer version of the tip of the breast with depicting the infection as described by Dr. Lawson. That'll be 9B.
And the next photo.
This is a photo of a hand. The blue glove is a medical provider that was holding it. Again, due to the contractures, we had to hold the arms and hands in positions for the photos to be taken. And this is a picture of a deep tissue injury. I believe this is of the index finger. It would be most likely then the right hand based off of what I can tell from the photo anatomic distribution. I believe this is her thumb, and this would be her index finger.
Your Honor, we'd ask that be moved into evidence. The injury to the right hand index finger would be State's Exhibit number 10.
No objection from defense counsel. All right, Exhibit 10 will be the deep tissue injury to the right index finger on the right hand of Ms. Sheila Marie, as described by Dr. Lawson, marked and moved into evidence of Exhibit 10.
And the next photo.
This photo, the blue glove is a healthcare professional holding Ms. Murray's chin up and deviating her head away from her right side. The yellow tube is again the nasoenteric tube that we would have placed upon admission to the intensive care unit for nutrition and medications. This is Ms. Murray's neck, on the right side of her neck, and there are deep tissue wounds and candidiasis present underneath the neck.
And what
this
is
candidiasis is a genus of yeast. Candidiasis is multiple species of the common yeast organism that we see that collects in warm, moist environments without exposure to air, and it happens a lot of times in areas that are difficult to keep clean due to contractures.
How long does it, if you know, how long does it usually take for that to develop?
It can develop over a period of several days to a week. It's not something, it happens fairly quickly with moisture. Because of where this is, I would imagine she did have a lot of drooling because she wasn't able to initiate swallow due to her weakness. And so she drooled a lot out of her mouth, and I believe the moisture would have collected under the right side of her neck. And that is probably why that built up there in that particular area. Most often you see yeast in what we call the intertriginous folds under the breast, in the perineum, sometimes between the toes. Those are the more common places that we see yeast collect due to the warm, moist environment, and where the pressure of our thighs or our maybe a pannus from an abdominal girth would collect moisture. It's not terribly common to see it under the neck, but it is seen in stroke patients or patients who are not able to control their saliva, and it builds up and can cause yeast growth.
Your Honor, we'd ask that that injury to the right side of the neck be State's Exhibit number 11.
Exhibit number 11 will be the photograph of the right side of the neck.
Yes,
correct. And the injury and the infection as described by Dr. Lawson to Ms. Murray's neck and facial area.
The next photo.
This is a photo of Ms. Murray's backside when you had rolled her. This is the nurse in the critical care unit. And the yellow would be what we call an iodoform gauze. It's a dressing that we place on open wounds to help promote wound healing. This is Ms. Murray's buttocks and the lower portion of her back. You can again see that at some point in her life, Mrs. Murray had quite a bit of subcutaneous fat deposits that have now been lost, which is why you have such redundant skin and skin folds. Mrs. Murray has what we call hemosiderin deposits, this pigmentation of her buttocks. We often see that in dependent portion. So that's why we see it on the legs, like in the previous photo. This would indicate that she spent a great deal of time on her backside and was unable to move herself to roll off of that. And we do develop those pigmentations the longer we lay in certain areas. You can again see signs of severe malnutrition. She has loss of subcutaneous fat. She has her tissue turgor, which is the tension of the skin, is gone. There's a loss of skeletal muscle. She has multiple unstageable deep tissue injuries present across her buttocks, lower back, elbow, moving into the middle of her thoracic spine, here underneath where her elbow was pressed on her side, here on her anterior superior iliac spine and iliac crest on her hip. Those are all just unstageable pressure wounds. The reason they are unstageable is because they have that yellow stuff that's developed in the wound base, and until we take a knife and cut that off, it's difficult to tell the true depth of the wound. That would have required a significant amount of what we call debridement, which is sharp excision of tissue bases. And in Mrs. Murray's case, had we debrided those wounds, it would be unlikely that they would heal with the degree of her malnutrition, which is why we were not planning to do those debridements and just do wound care and provide nutrition.
Your Honor, we'd ask that the photo of the lower back side with those injuries be moved into evidence as states Exhibit 12.
Okay. No objection.
All right, without objection, the back, elbow, and buttocks as described in the photograph reviewed by Dr. Lawson will be marked as Exhibit 12 and moved into evidence.
I'm going to ask you to look at the next two photos, like we did Exhibit 9. And where are those photos of?
These are photos of Mrs. Murray's back and right scapular spine, which is the shoulder blade, upper T-spine, right behind the right shoulder.
Okay. And that photo that in your right hand,
Yes.
could you tell us what that depicts?
The medical personnel rolling Mrs. Murray up on her side. Her left side would be down in this photo. You can see her hair and head here. This is her spine. You can see the curvature of her spine. And this is her right shoulder area back, the back of her shoulder. This is her arm. Again, you can see a redundant skin fold where she's lost subcutaneous fat. You can see the hemosiderin deposit where she's been on that part of her body and has developed deposition of blood vessels, and it's collected the hemoglobin has made this discoloration. There are some scattered deep tissue wounds here, and then a very, very large, this is what we would consider stage 4. The reason it's stage 4 is you can see the beginnings of muscle and bone where the scapula has eroded through the skin, and necrotic skin edges are present at the base of this wound.
Your, we would ask that that be moved into evidence as states Exhibit 13A.
All right, the photograph just described by Dr. Lawson, the back, right, and right shoulder, where she's rolled over on her side, as described by Dr. Lawson, will be marked and moved into evidence as Exhibit 13A. Do you want that one?
If you keep the other one, we're going to talk about that.
Sorry,
Okay, so that's okay.
it's got a measuring tape in it.
And would you describe that photo?
This is a photo that's just zoomed in of the same previous image with a measuring tape held by medical personnel. This is just for dimension. The actual open wound measured 5 centimeters in maximum length, and the peri wound, which is the tissue that's at risk next to the open wound, measured an additional, it appears to be 2 centimeters in maximum diameter, about a centimeter of peri wound around all of the open wound in a circumferential or circular fashion.
Here we'd ask that that photo be moved to Exhibit 13B.
All right, the Exhibit 13B, without objection, will be marked and moved into evidence. That photograph that includes the measuring tape referenced by Dr. Lawson.
Dr. Lawson, after having physically examined and seen the injuries to Ms. Murray upon her arrival at the hospital, what was your immediate thoughts with regard to her care?
I have a lot of thoughts and a lot of emotions, and I try to distance myself from emotion when I record medical facts. The fact that I documented the manner in which I did was probably indicative of how emotional we all felt on her arrival. I underlined severe with 2 lines, neglect. This is an emotional response to what I saw when I saw this patient in the trauma bay. I cannot comment on how Mrs. Murray sustained an open fracture dislocation of her right ankle with necrosis of the bone. I don't know how that could have occurred. Fall mechanisms are relatively common in mobile patients. They're very uncommon in patients who are bedbound. Mrs. Murray had been bedbound for some time, given the degree of pressure necrosis, hemosiderin deposits, and contractures that she had. All I knew is that we needed to get her admitted to the hospital where she could receive care and be safe. We could provide nutrition. And when we see this constellation of presentation symptoms and wounds, it is our practice to consult adult protective services due to concern of severe neglect in a patient who is not able to express with their own voice what's happened and who cannot protect themselves.
You had talked about the fracture to the right leg.
Yes.
What was the treatment provided for that?
Immediately was to try to provide moisture to the exposed bone. That is standard treatment for what we call open fractures. They used to be called compound fractures, which is what a lot of lay people call them. Anytime there's an exposed bone, we try to apply moisture to it to keep the bone from drying out or desiccating and decaying. There was already evidence of decay, so we would have temporized that with a warm, moist gauze dressing and wrapped it. We consulted the orthopedic service after that so that they could evaluate the patient to see if there was any potential for salvaging of that limb.
And as the attending physician, did you consult with them about what would be the best treatment for her?
I'm not an orthopedic surgeon, and so best treatment I usually defer to the experts in their care. Certainly she needed debridement and washout of the wound due to the evidence of decay and infection present at the base of the bone. We would have talked about that. They would have taken her to the operating room, standard practices within 24 hours of presentation. We administered tetanus vaccination and antibiotics, which is standard of care for treatment of open fractures. And there is a injury severity score called the MES, or Mangled Extremity Severity Score. The MES score is something we use usually in acute trauma to determine the degree of likelihood of limb loss. We did not calculate the MES in my history and physical, but with an open fracture dislocation with bone decay, the likelihood of limb salvage for that is quite low. The degree of angulation of the foot away from the ankle and the fact that we could not reduce it. Reduction of a fracture is standard of care as well, where we bring the bone back into normal alignment. And this fracture was old enough that I could not freely move the foot back into a normal anatomic alignment, as it was at a right angle to the ankle, and normally it would have been in alignment. The likelihood of limb loss is significant for that type of presentation, and Dr. Gotts and I did discuss that. His plan was to take her to the operating room and to try to do some debridement and irrigation and replace this external fixation device, and then later discussion about whether or not we should proceed with amputation.
Okay. Do you know if her leg was amputated?
It was not, because Dr. Goss deferred that to my clinical judgment. I'm certified to do amputations. He's the orthopedic specialist for limb salvage. I did not feel that an amputation would have been in this patient's best interest. She would have had a very difficult time healing any wounds that I would have created surgically due to her malnutrition. She was in an advanced state of debility, and given that she was in such a severe state, my inclination was that she needed to have a palliative care consult with goals of care discussion. I felt that she would have been best served by providing comfort rather than an amputation, which would have caused a significant amount of pain in what I consider to be an end-of-life scenario.
Based on your training and experience, if she had received medical attention earlier with regard to the fracture of her right ankle, would that have possibly changed the prognosis?
I believe it would have possibly changed the prognosis of the ankle fracture. The treatment for ankle fracture would be reduction and fixation within 24 hours of presentation. I don't think this was anywhere remotely near 24 hours of presentation. Would it have changed her overall prognosis of her end of life? Not necessarily, because she had other things that were contributing to her debility and to what I consider to be an end-of-life scenario, the majority of which centered around the severe malnutrition. When you've lost that much of your skeletal muscle mass, the likelihood that you would heal anything, even if it comes with an acute presentation, is very low.
Okay. saw Ms. Murray in 2019.
Yes.
Is there anything about this case that particularly has stood out to you?
Yes. I've been doing my job since I began residency in 2005. I've been a certified surgeon in the state of Tennessee since 2010, and I've been in the active practice of trauma, which these things present as traumas usually. I've seen cases of neglect and abuse in both children and adults, and there are patients that stand out in your memory. And Mrs. Murray will always be in my memory because of the severity of the neglect and how much compassion and emotion